Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to the NewlyMeds podcast. Today we have our third edition of Quik Crits, and we're going to be diving into a little bit of what we talked about earlier in the month with postpartum hemorrhage. We're going to do a deep dive into TXA and Pitocin. We're going to break down a little bit more of the pharm, the uses, the contraindications, the side effects, and really just get you comfortable with these medications that you have at your disposal. And before Dan and I were recording this episode, as always, we talk a lot about the topics that we want to post and some of the things that we want to put out there. And I was telling him that I was never really comfortable with Pitocin before I went to nursing school. And I was a paramedic and I knew what the medication did. I understood when to give it, but it's something that I never used. I never really used it as a paramedic student, never used it in the field. And it wasn't until I went to nursing school that I got comfortable with that medication. And it's similar to TXA. It's something that's new. I think a lot more paramedics are comfortable with TXA because of how new it is and how much it gets pushed on us as providers. But really, we need to get comfortable with why, when, and what these medications do so that when we deploy them in the field, it's done appropriately. So without further ado, Dan, tell us, what is TXA? Why the heck are we giving this thing?
Awesome. Yeah. So TXA, love TXA. So it is a synthetic lysine analog antifibrinolytic agent. We'll go over some of the $20 descriptions here, and then I'll break that back down to the more $1 or $2 descriptions for people like myself who, unless I'm looking at all of these words and writing it down and trying to break it down on my own, have no idea what you're saying. So how this works is that it binds to lysine receptor sites on the plasminogen and plasmin, and these enzymes are what are responsible for breaking down fibrin clots, which is the process called fibrinolysis. And what TXA does when it binds to these lysine receptor sites is that it blocks this plasminogen from converting into plasmin, which then prevents plasmin from binding to the fibrin. And this prevents the clot from being broken down through the fibrinolysis. So, what does that ultimately mean? It keeps the clots from falling apart. It stabilizes them and it helps prevent that breakdown of clots. And as we all know, hopefully at this point, for paramedics, nurses, and EMTs at this point, we know that clots are good when it comes to bleeding and the prevention of too much bleeding. Why this is important is that especially when we are following up on our postpartum hemorrhage conversation, this is going to help keep those clots in place and help slow that postpartum hemorrhage. Obviously, we will get into more of the other uses, particularly trauma, as well in a few minutes. But one thing to keep in mind when we are utilizing TXA as our pharmacological option is think back to what I just said. This stabilizes clots, this prevents clots from breaking down. This is not a clotting agent. This does not cause the creation or formation of new clots. It is only preventing the premature breakdown of the existing clots. I think that's one thing that we need to make sure that we're keeping in mind when we are using or considering using TXA.
So, Dan, you're telling me TXA has absolutely nothing to do with stopping bleeding magically.
There is no magic. It's all chemicals. It's all chemicals and it's all stabilization of what the body's already doing. I'm going to try to find it and put it in the show notes here. Hopefully you guys looking at the show notes will see this. If not, do some research and on the old YouTube there and see there's this, it's a super corny video. It's literally, I think, from like London School of Dentistry or something like that. And I'm pretty sure it was made in the 80s and it looks like it was made in the 80s. But this video does an amazing job, in a corny way, but an amazing job of breaking down what this does. I'll try and link that as well. But yeah, absolutely no formation of clots, just simply stabilizing our existing clots.
Yeah, it's such a great point you make, Dan. And there's also an Australian, as we're talking real quickly about some videos that we're gonna link. There's an Australian nurse who does a really good job about using pasta to talk about bleeding and clotting and the plasmin and plasminogen that occurs using pasta and pasta sauce, sort of as an analogy and a visual training aid to take a look into that. And I think that goes hand in hand with TXA. So
I don't
we will definitely link those in the show notes
yeah, I
for
don't
you.
think
But
I've seen
yeah,
those, so I would definitely look forward to finding that with you because I would like to see that.
yeah, it's pretty entertaining as well. But tell me some more about it because I'm learning more every second here from you.
Yeah, absolutely. So anytime we talk about a drug, obviously we want to know about the pharmacokinetics. So a big thing is we're going to be giving this IV. We'll talk about doses here in a few minutes, but we're going to give this IV. When we are utilizing this drug IV, onset of action is usually within 1 to 2 minutes, with the peak plasma time in the 5 to 15 minute range and a 2 to 3 hour half life. There is minimal hepatic metabolism that goes with this, so this is not going to be metabolized that way, and it is typically going to be excreted through the urine. And there is reduced renal clearance, so we want to make sure that in our kidney impaired patients that we are adjusting the dose as appropriate within our protocols. Just like we said, our main primary uses for TXA would be postpartum hemorrhage and trauma. We talked in the last episode the woman trial, and again, we'll link the Crash 2 trial as well for trauma. Early administration of TXA in these patients that qualify under the postpartum hemorrhage and traumatic bleeding both show substantial reduce in morbidity and mortality. Other uses, surgical bleeding, so post tonsillectomies, any of those types of bleedings that we can't get to from an external factor to try and control bleeding through direct pressure and those types of measures. Epistaxis, menstrual blood loss in general, even outside of like a postpartum scenario, any of these significant bleedings can be benefited through the use of TXA. So when we look at TXA, real quick, some of our contraindications, our precautions, an absolute on our absolute side, any type of intravascular clotting, so untreated DICs, DVTs, PEs, subarachnoid hemorrhages, any of those types of intravascular clotting or bleeding along those would be absolutely contraindicated. And then some relative contraindications that we want to make sure that we're keeping in mind. So any type of previous history of DVTs, PEs, MIs, or any other type of thromboembolic diseases, we want to make sure that we are keeping that in mind. TXA over studies does not necessarily show a significant increase of clot risk when we're using it correctly, which based on our protocols fall within those parameters, or most protocols that I've seen anyway fall within those parameters. And typically these benefits are going to outweigh the risks, but it is something that we do want to keep in mind there. We did talk about renal impairment. Also, we want to keep in mind our seizure disorder patients or a predisposition to seizures. Prolonged infusions can lower that seizure threshold.
Mm.
Typically, it's related to GABA receptor antagonism in the brain. We want to make sure that we're keeping that in mind. Again, typically the benefit's going to outweigh the risk, but something to keep in mind there. And from that, I know when we talk about dosing, typically most protocols that I've seen are going to be 1 gram in normal saline over 10 minutes. We want to make sure that we're administering that over the 10 minutes, that we're not causing hypotension with rapid infusions. You can certainly see some hypotension with that, but within that 10-minute parameter, we are usually good from a hemodynamic standpoint. Follow-up doses, especially if we're doing like a hospital to hospital transfer, they can do another gram typically over 8 hours when we're looking at a hospital continuation of the TXA dose. But that's only going to be if the first administration was done within that 3 hours. And I think one of the questions that I've always gotten when we talk about TXA is why this 3 hour window? And this 3 hour window, I don't want to say comes from, but was largely substantiated by the Crash 2 trial. And that trial showed a significant reduction in mortality within that first 3 hours. And you have that drop off after that 3 hours. So the morbidity mortality rates kind of threshold at that 3 hour window there. And typically, if we think about why that is because we're kind of within that window. We are with TXA, we're stabilizing older and partially degraded clots before fibrinolysis can occur at that stage. Whereas if we're waiting past that 3 hours, we're probably not um, intercepting that fibrinolysis early enough for the breakdown of those clots. And then also, we want to help preserve the fresh clots in the time that it matters the most, right? Somebody is actively bleeding. We want to make sure that any new clots that are forming, that we are stabilizing those and preventing that breakdown. I think the big key takeaways when we think about TXA is making sure that we are doing that within the 3 hours. I know we talked in the previous episode, early recognition and early administration, obviously following our basic interventions, but making sure that we are keeping in mind our thrombosis patients, renal impairment patients, and then obviously any type of active clots or subarachnoids. Hypersensitivity, obviously, for every drug, make sure that they don't have any hypersensitivity to the drug. But the other big thing too is just keeping in mind that this is not forming new clots, this is not helping form new clots, this is not creating clots, this is simply stabilizing the clots that we have already made. So I am a huge supporter. I know Will and I have talked about some of the other uses for TXA, including nebulized TXA for those post-tonsillectomy bleeds, um, intranasal or just intranasal TXA for epistaxis. There's a ton of different uses for this. Obviously, work within your scope and within your protocols, but explore what you actually can do within the protocols, because a lot of times we find that we do have a little bit more use, especially out of this drug, that could be very beneficial than what we kind of realize. So, Will, I think if you don't have any other questions on TXA, I would love to hear more about Pitocin, especially from your nursing background.
Yeah, Dan, no, I think you gave some really key information about TXA, and it's a medication that I love as well. And everything that we have pre-hospitally, all these medications, when we deploy them in the right sense, they're so beneficial to our patients. And so I think you really, again, hit the nail on the head, making sure we're getting it within that time frame and that we're doing all the right things on the front end to make TXA effective. But now that you talked a little bit about TXA, I get to dive into Pitocin, which I never really got super comfortable with, like I said, until I went to my maternity class in nursing school. And I really got comfortable with a lot of these different medications that are used for maternity and labor and delivery. And Pitocin is one that you see all the time. So, in order to really understand what Pitocin is, you have to understand what oxytocin is. And oxytocin is a natural hormone that's produced by our hypothalamus in the posterior pituitary gland. And it triggers uterine contractions during labor and after delivery. And so, bear with me here because I 1000% have this memorized. But like Dan said, as we're talking about some of the high level things in the pharmacokinetics, the oxytocin receptors are in our body. And it has, when we think about Pitocin, you just think of synthetic oxytocin. It's the same thing, effectively identical to the hormone that we have, except now we are administering it through an IV. So we're actually giving it to the patient. And so what Pitocin does is it acts on these oxytocin receptors, which is a G protein that's coupled on uterine myocytes. And so when we activate this, it leads to a phospholipase CIP3 release of intracellular calcium. And then this introduces a pathway that causes contraction.
Oh,
There's a
yes,
lot
I
of
had that
stigma.
memorized too. Yeah.
Yeah, I just really wanted to commit that pathway to memory. I think it's so important. So, what the heck does that mean? Well, essentially, during pregnancy, these oxytocin receptors increase and they're at their peak sensitivity during early labor. And so, when we introduce Pitocin prior to a delivery, we're really working on stimulating that contraction so that we can encourage the baby to start coming out. And so, like any medication, the longer we're exposed to it and how many times we're exposed to it will desensitize those receptors. So the first key thing that I learned with Pitocin was always asking the patient, how many deliveries have you had before? How many times have you received Pitocin? Because when we talk about doses, that's really important because their receptors might not react as well as someone who has never delivered a child before. This is their first pregnancy, first delivery, and they're receiving Pitocin. They might not need much at all. And so the clinical indications of Pitocin are really to induce and augment labor. And so we're giving Pitocin so that we can speed up and strengthen these contractions when we are watching a mother have not so strong or very infrequent contractions. And Pitocin is a unique medication that we don't really talk about it in milliliters or micrograms, but we talk about it in units. And there's a range of doses that you can do that you would add to about a half liter or liter of normal saline or lactated ringers to cause contraction. And so when we're talking about augmenting and inducing labor, we want to make sure that we're seeing good, strong contractions that last for about 45 to 60 seconds. And we get 3 contractions in about a 10-minute period. And so we can titrate Pitocin to get those strength of contractions. But pre-hospitally, we're not really using Pitocin for that. So that's a little bit of the nursing background, maybe a little bit of the interfacility, but I don't even think you would ever touch that on an interfacility because they should be delivering on a labor and delivery floor. That's the best spot to have a kid. So when would we use it pre-hospitally? Well, we talked about it earlier this month, and it's with postpartum hemorrhage. And so, how the heck does something that stimulates contractions to deliver a baby help with postpartum hemorrhage? And it's exactly that. Because we are contracting that uterus, we're working on shrinking it. So, after that baby is delivered, after that placenta is delivered, we're using the Pitocin to strengthen that uterine contraction and try to get that bleeding to stop. And so, oftentimes after fundal massage, this is something that you can use first line. Again, you're always going to want to refer to your local protocols with how much to give, when to give it, and exactly how to titrate that. But there's really good data out there on how Pitocin works to reduce that postpartum hemorrhage severity and mortality that's associated with it. And so, as we think about it in EMS, I could dive deeper into the nursing side of it, and we can talk a little bit about how Pitocin's titrated prior to delivery. But I really only want to focus today on post delivery and postpartum hemorrhage. And so, using Pitocin is such a good tool that we have. Dan talked about TXA, and that's something you absolutely can use in postpartum hemorrhage. And Pitocin is also something that you can use. And so, I think it's really important to remember, like Dan said, that we are using the appropriate assessment techniques when we are deploying these medications in the field. And so with Pitocin, there's really no major contraindications, not even any relative contraindications, because it's very similar to medications like norepinephrine and epinephrine, is that our body naturally produces oxytocin. And so giving Pitocin, no one's going to have some sort of massive allergy to it. Like if you were to give someone epinephrine, they might not feel great. They might say that their heart's racing, and you could call that a hypersensitivity, but also you just got a shot of epinephrine. So I think my heart would also be racing. Pitocin's in a similar sense. There's no real allergy. There might be a hypersensitivity, but the only contraindication in my mind that we talked about on the last episode that we have to consider is that that uterus is fully intact. If the uterus is not fully intact, we should not be giving Pitocin because it's not going to do the effect that we want. And something else that I would actually consider a contraindication, maybe not in the sense of allergy or another contraindication if they were to have like, a bleeding disorder or something like that, is ensuring that all the babies have been delivered, that we want to make sure that there's not another fetus in the uterus when we give this Pitocin pre-hospitally for postpartum hemorrhage, because if that is the case, we're going to cause more contractions, and that might even be harmful for the fetus that's still in there waiting to be delivered. So it's really essential pre-hospitally to make sure that that uterus is completely intact, that there was no uterine rupture, and that the placenta has also been delivered. I think that using Pitocin before the placenta has been delivered pre-hospitally for postpartum hemorrhage can be a recipe for disaster. So, as we talk a little bit more about this, some things to monitor are the patient's blood pressure, the heart rate, how mother is reacting to the medication, making sure that she's still comfortable on it. And again, as we are getting more pumps pre-hospitally, this is 1000% a medication that should be on a pump. It shouldn't be a titrated to effect type of medication. We should get it on a pump. We should know exactly how many units we're giving per minute, per hour, and we should titrate this medication to the effect of that when we get our units of titrating to uterine contraction and all those things. But it shouldn't just be something to where I'm going to open it wide, and when the bleeding stops, I'm going to close it halfway.
No matter, so we're
We
just eyeballing.
Yeah, we're just eyeballing the drops that come out, right? No, we really want to have this on a pump and make sure that the patient's feeling the effects of it and not being overwhelmed by it, because again, it is a hormone. It is something that they naturally produce, but it's not always the most comfortable thing, and we want to make sure that the patients are tolerating the medication and the procedure well. So then we just threw a lot of information at them, but I think the gist of this episode is to dive deeper into why it's so important to study the medications that are in our toolbox with EMS. I was very uncomfortable with Pitocin. I saw it in my medication box. I knew that I had it. I knew what the medication was. I knew the indications. I knew when to give it. But when it came down to it, I don't know if I would have ever pulled the trigger on it. Luckily, I've never had to. Like I said a few weeks ago in the episode, all of my pre-hospital deliveries have been great. But even though I knew these medications, I never got comfortable with Pitocin until I went through nursing school. And that's not to say that you need to go to nursing school if you're a paramedic. Absolutely not. I think always progressing your education is really important and it's awesome, but it's not always realistic. But what is realistic is taking the time, the effort, and just the care to dive deeper into what these medications do to better yourself as a provider. Because at the end of the day, you may be in a situation where you have to pull the trigger on this medication that you don't use that often. It's not like Zofran or something that we use all the time. And you really need to know all about it because your patient relies on you to make the right decision on their worst day. And so understanding TXA, understanding Pitocin, and really understanding all the other medications that are in the box and the tools that are in our belt as a provider is critical to being in the field and being safe and effective and delivering the highest standard of care. Dan,
Absolutely.
what
And
else do you
Will,
have?
I think to couple what we talked about on the last episode is with this early intervention and early recognition, the comfortability with these medications helps us be more comfortable to pull that trigger early, to escalate that continuum of care early, and to not second guess whether or not we should be doing that, which often breeds that time frame in which we're going to have more negative effects by not offering that intervention early. So I think the comfortability with these medications from a pharmacokinetic and from a knowledge standpoint truly helps us in pulling the trigger early on these interventions. And Will,
Absolutely.
I would be remiss. I know one thing that we completely forgot to bring up on the last episode and made me realize and remember that, hey, we totally glossed over this as we were talking about all of this oxytocin here, is one of the most important things that we can do that we completely left out in our basic interventions for postpartum hemorrhage in the last episode is skin to skin contact.
Yeah.
Skin to skin, we hear it, it's all the rave, everybody knows, everybody's heard the phrase, but that skin to skin contact naturally creates a pituitary release of oxytocin within the mother. And as we just learned about Pitocin and oxytocin, and all of the benefits that we're going to see from a postpartum hemorrhage standpoint from oxytocin, that is something that we can do, permitted the care of mother and child allow for this, obviously. But that is something simple that we can do and encourage and, provide the facility for that skin to skin contact. And we can have that natural progression of oxytocin release to help with that postpartum hemorrhage just simply through the skin to skin. So I think that I wanted to make sure that we brought that up on this episode, because I know we missed that on the last episode, and that is something that is massive when it comes to postpartum care in general, but especially when we're talking about postpartum hemorrhage.
Definitely, Dan. That's such a great point.
Yeah, and I think, Will, if you don't have anything else to add, we'll go ahead and wrap this up. As always, we would love to hear if there's any other medications that you guys maybe don't feel as comfortable with that we can kind of focus on in another Quik Crit episode, where we can break down these medications in a relatively fast fashion like we did for TXA and Pitocin today. So shoot us a message if you have any other uses or any other experience that you would like to throw out there, whether that be on TikTok, Instagram. Shoot us an email or a DM, but make sure you get in contact with us about that. And if there are any other medications, like I said, that you want to go over, please let us know, and we would love to go over that. I know I and Will both love going over pharmaceuticals, so we would love to hear anything that you guys would love to know about. But yeah, with that being said, until next time, trust what you know, treat what you see, and always remember to stay curious and stay humble. Catch you guys next time.